Welcome everybody to today's Consortium of Universities for Global Health webinar. Today we have a very exciting and important webinar on health in areas affected by violent conflict, a time for academic global health programs to respond. I'm Dr. Keith Martin, the Executive Director of CUGH. We know war is really a political failure, and the consequences of war are of course devastating. The actors are both state and non-state. But what is clear today is that the primary victims of conflict are in fact civilians and vulnerable populations. So how do we safeguard those populations in this very unstable environment? How do we ensure that they receive the healthcare and essential needs that they require for their survival? Well, today's webinar will address those and many other important subjects. I would encourage you, we have our annual conference coming up in March, so I would encourage you to please register for it, cugh2021.org, where you'll see many of these issues brought forward and have time to discuss it. So I'm really pleased today to introduce you to the moderator of the panel today. The moderator is Dr. Michelle Berry. Dr. Berry is the director for the Center of Innovation and Global Health at Stanford University. She is also the chair of the board of directors for CUGH. Michelle, welcome and over to you.
Thank you, Keith. Good morning, good afternoon, and good evening for whoever is on this webinar. It's a pleasure to introduce our august panelists for the CUGH webinar, whose purpose is to discuss ways in which to deliver impactful humanitarian healthcare in settings affected by violent conflict. This webinar was prompted by a 4-part series published in Lancet on January 25th on women and children's health and nutrition in the context of armed conflict, to help analyze the gaps and provide guidance as well as long-term actions for a more effective humanitarian health response. More than 630 million women and children, it's a staggering 8% of the global population, are impacted by armed conflict. This series covered a variety of important issues, but was broadly concerned with several critical themes around the changing nature of armed conflicts and how to prioritize interventions for women and children caught up in the fallout of these violent conflicts. Our first speaker today is Dr. Paul Wise, and I'm going to introduce all the speakers rather than intermittently interrupt. Our first speaker, Dr. Wise, is the Richard E. Berman Professor of Child Health and Society and Professor of Pediatrics and Health Policy at my institution, Stanford University. Our second speaker will be Dr. Zufi Bhutta, the inaugural Robert Harding Chair in Global Child Health at the Hospital for Sick Children in Toronto. Following Professor Bhutta is Dr. Neha Singh, co-director of the Health and Humanitarian Crises Center and assistant professor at the London School of Tropical Medicine and Hygiene. And fourth, but not last, will be Professor Halagatas, associate research professor and director of the Center for Research on Population and Health at the American University of Beirut in Lebanon. So just some logistics. Please write, we always get many Q&A and we would like to leave 20 minutes for Q&A at the end. So start writing your questions in the Q&A and we will try to get to answer as many as possible. So Paul, take it away.
Thanks very much, Michelle. I'm going to share my screen when I get the prompt. I'm not getting the prompt. There we go. Our paper attempts to fundamentally bridge the fields of humanitarian health and human security. It attempts to provide in one place an overview of the political and security challenges that can transform laudable humanitarian intent into a complex and at times dangerous humanitarian reality on the ground. It has required insights from diverse disciplines, including international law, human rights, political science, military and security studies, anthropology, as well as humanitarian and health expertise. It is also required seeking guidance from communities experiencing organized violence, voices that remain too often unsought. Our approach recognizes the importance of abstract humanitarian concepts and describes the international legal and human rights frameworks and policies that guide humanitarian action. However, it is also fundamentally directed at confronting the pragmatic brutality of violent conflict, a reality in which humanitarian objectives must contend with the ravages of political ambition and the exercise of power. There's no definitive day-to-day rule book for protecting non-combatants and health providers in areas affected by violent conflict. Most conflicts are intrastate or civil wars, and most now are protracted conflicts lasting more than 10 years in duration. However, this figure can broadly outline the humanitarian endeavor in war. Although humanitarian intervention is concerned with many aspects of violent conflict, the central mitigating humanitarian strategy operates through two related mechanisms. The first is preventing non-combatants from violent attack in the first place. The second mechanism is the humanitarian provision of care and comfort to non-combatants when this protection fails. The health outcomes of this interaction between violence and its mitigation can in turn take two forms. The first are the direct effects, the physical and mental trauma caused by the direct exposure to bombs and bullets. These direct effects have traditionally been the arena that has generally preoccupied humanitarian protection and medical responses. But there's a second arena of outcomes, the indirect effects, which are the effects due to the destruction of the essentials of life. These include the destruction of shelter, food and water supplies, electric grids, transportation networks, and health systems. These effects are ultimately expressed as elevated rates of malnutrition, disease, maternal and child mortality. Almost always, the indirect effects dwarf the direct effects. Now, we summarize our observation as three key messages. Perhaps the most fundamental message of our paper is that the political and security challenges confronting humanitarian action are intensely dynamic. The nature of warfare, its objectives and strategies, as well as the nature of combatants and their portfolios of violence can vary and evolve quickly in response to the changing array of security and political conditions in areas of violent conflict. Of special concern are proxy and hybrid strategies that link the operations of local fighters and militias to regional or global powers with deep resource pockets and highly sophisticated intelligence and cyber capabilities. There has also been a proliferation of armed non-state combatant groups. In Syria alone, more than 1,000 of these groups have been active since the start of the conflict in 2011. Often, non-state combatant groups, as well as many state militaries, will blend political goals with criminal activities. The line between grievance and greed has been completely blurred. This complex interplay between ideological, political, and criminal motivations can be difficult for humanitarian actors to discern, which in turn enhances their vulnerability to attack. These complex and dynamic security environments can also exacerbate the impact of infectious outbreaks, such as COVID-19. Experience from the Ebola outbreaks in West Africa and the Eastern DRC, and more recently from COVID-19 in unstable areas, we've found that the provision of health services can quickly become currency in the struggle for power. In some areas, state security forces and armed non-state combatant and criminal groups have taken charge of distributing COVID information and supplies in a strategic effort to enhance their legitimacy and ultimately their power. Humanitarian protections and norms have always depended on collective global order and a support from powerful states. However, recent political developments in the United States and Western Europe and the enhanced global posture of China and Russia have had the potential to destabilize longstanding commitments to international institutions and humanitarian cooperation. In this context, it is important to recognize that in areas of violent conflict, local communities, while experiencing great suffering and pervasive risk, are almost never passive. Local humanitarian responses are often the first and most trusted forms of community-based protection and can help ensure the effectiveness of international assistance. In sum, effective humanitarian provision will need to adapt and adapt quickly to the contours of organized violence in diverse settings around the world. Our suggestion is that this will require humanitarian health workers to have a far deeper understanding of the political and security dimensions that shape humanitarian need, access, and safety. This will not only require greater cross-disciplinary engagement, but also respect for voices that are rarely heard. It will require respect for local creativity and resilience, the lessons generated by communities tormented by conflict, women confronting conflict as they struggle for greater social freedom, children deprived of stable nurture and education, adolescents losing hope in the promise of adulthood, and combatants responsible for protecting non-combatants while their comrades fall around them. This article argues that in the end, it will be the effective negotiation of the political and security dimensions of armed conflict that will best ensure that women and children and all non-combatants will find protection, that health workers will be able to provide some pragmatic expression of humanitarian compassion to all those enduring the horrors of war. Thank you. Sophie?
Thank you very much, Paul, for that wonderful background. And it also underscores why this area was so important for us to negotiate and build our consortium and academic collaboration on. So my role in all of this, if I can share my slides, is principally to share with you what we have done as an academic consortium in looking at this from the lens of academia engaged in this. So let me see if I can, how do I share my slides?
If you select the PowerPoint button down at the bottom row, it'll pull up your PowerPoint.
I just have a very narrow view all of a sudden. Just 1 second, let me see. Right.
There we go, great.
So can you see the slides in their entirety?
Yes, just put it in presentation mode real quick and then swap the display.
Thank you.
Great.
All right. So I'm going to present to you what we've recently done as the Branch Consortium, which stands for Bridging Research and Action in Conflict Settings for the Health of Women and Children. It's a consortium that has worked together over the last 4.5 years. It comprises of academic research partners who got together, and in addition to these core partners that you see over here, represented by not only my own institution, but Stanford, which played a lead role, Harvard, Hopkins, London School of Hygiene and Tropical Medicine, and Aga Khan University. We had a large number of in-country research partners, worked closely with some UN agencies, Countdown and PMNCH over the last 4 years to bring together this body of work that I will be sharing with you partly, and my colleagues will be sharing with you some of their own components within this. As I said, in addition to the core steering committee, we are very grateful for the support that we received from the Bill and Melinda Gates Foundation, IDRC, the Norwegian government, and Family Larsen Foundation, PMNCH, and the academic collaboration that we had with a number of publishing groups in bringing our work forward. Our activities were largely geared towards filling global gaps, and we undertook a systematic exercise at the beginning to see where were the areas in which there was very little information. And as the late Hans Rosling said, this was largely a fact-free space in which people filled with numbers based on conjecture as opposed to real scholarship. So estimating the levels and distribution of maternal child health, newborn-related mortality that was directly or indirectly attributable to conflict was extremely important because we had widely diverse estimates on this. Some attributing very little and others attributing too much to what conflict was contributing to the global burden of disease in this space. We wanted to critically examine existing guidelines and documents related to normative guidance. And we wanted to do this through a very systematic look at existing information, even if it was available through only gray literature. But most importantly, we wanted to have a look at what was going on actually in countries, to assess the country situations in terms of response. And my colleague Neha Singh will be sharing that with you, and Dr. Hala Gattas will be sharing some of that experience from specific regions. And at the end, we tried to bring it all together. So before I go on to the Lancet series, a lot of the background work and the detailed scholarship was published in 2 specific collections. So the 10 country case studies with the background and methodology were published in Conflict and Health, and you can see the link here, they're all freely available. And the systematic reviews on intervention delivery strategies, existing guidance, and where the gaps were have all been published in the BMJ family, and they are available through the link that you see on the screen. The systematic reviews looked at not only things that are existing within guidelines, such as water sanitation, hygiene interventions, trauma rehabilitation, but also looked at things for which the evidence is only just emerging. Mental health, psychosocial support, infant and young child feeding practices, and a fair amount on what we typically recognize as infectious disease interventions, including vaccination strategies. Specifically, I'd like to point out to you one of the biggest gaps in this space, which is around non-communicable disease interventions, and we looked at whatever was available. So I strongly recommend this as background reading to some of the stuff in the Lancet series itself. The Lancet series comprises of 4 papers and 2 linked comments. The 4 papers, of which the first one, Professor Weiss has already alluded to, looked at the background, the political and security dimensions, but the others are specifically focused on some of the measurement aspects and the intervention development, or the framework for intervention development, and then we have a way forward comment. So let me start with what we know newly on the numbers, and this is work led by Professor Eran Ben-David from Stanford in collaboration with a number of branch consortium partners, including ourselves. And some of this work was actually published ahead of the Lancet series. So these 2 papers are what I call pivot papers on looking at child deaths in Africa related to conflict in a very granular manner, and also maternal deaths in Africa related to conflict based on geospatial clustering and monitoring. And some key messages emerge. First, between 1995 and 2015, not a small proportion, but over 11 million deaths of women and children in Africa could be attributed to the direct and indirect effects of conflict. Also importantly, Dr. Ben-David recognized and documented the relationship of severity, chronicity, and distance on child mortality. And what he was able to show from this numeric analysis was that the closer you were to the epicenter of conflict, the greater the likelihood of impact on mortality due to both direct and indirect effects, and that this effect, this ripple effect of conflict, could be seen as far out as 100, 150 kilometers away from the epicenter of the conflict itself. Importantly, these relationships told us that the indirect effects of conflict on infant and child survival as well as maternal survival were several folds higher than the number of direct causes of death from armed conflict itself, understandable from the impact on health systems and other services that were available. And this was widespread. So from his paper, you could see that this impact of conflict on maternal child health outcomes pervades throughout low and middle income countries in the very geographies where mortality clusters. So you see this across sub-Saharan Africa, parts of Middle East, and the AFPAC region, and also, not surprisingly, in the emerging areas of conflict that have affected and displaced a large number of people in Southeast Asia. I've already talked about the risks within certain distance, but just to say, if you just focus on within 50 kilometers of the conflict itself, what Dr. Ben David is able to show that the greater the severity of conflict, and you look at the change in mortality rates, you're looking at a proportional increase between 15 to 26, 27% in various parts of the world in terms of child mortality. So the key messages from this initial work on overall burden was that this number of women and children affected by conflict has grown steadily over the last 2 decades, both by virtue of increasing population size, urbanization, and an unfortunate steady state of increase in conflict events around the world. And the number of women and children who are either displaced or resided dangerously close to armed conflict events is not small. It's over 600 million by our estimates. And the mortality risks from non-violent causes increases substantially in response to nearby conflict. And we estimated, as I mentioned, more than 10 million deaths related to this. And the impacts are due to a wide variety of issues, and they relate to the risk of malnutrition, infectious diseases, poor mental health, and poor sexual and reproductive health. And the data on adolescents in particular in this space is very marginal, very sparse. Now, a big question emerges as to what can be done about it. And my colleague, Michelle Gaffey, led this exercise of looking at how these interventions, both from the global evidence and existing guidelines, could be delivered a little better. And was there a possibility that we could have a framework for decision-making as to the mix of these interventions a little better? And the framework, the decision-making framework that we recommended was based on some initial work done on immunizations about 10 years ago. And it starts off with a situational assessment and looks at the contextual feasibility of delivering specific interventions through specific pathways and platforms, allowing us to prioritize this in a specific manner. In the interest of time, what I would mention is that there is a because of the risk that I've already mentioned in relation to proximity of conflict, we have taken the position that there are some interventions which are just not feasible very close to the epicenter of conflict, and therefore you should have a hierarchy of interventions that are focused a lot more on just saving lives in the immediate proximity of conflict. And as you move outwards to more stable spaces, logically focus on interventions that you can deliver reasonably and can impact outcomes which affect long-term survival as well as health of people, including mental health interventions, sexual and reproductive health interventions. So there's a hierarchy of interventions that relate to not only camp settings, but also stable areas with dispersed populations and communities. And these are related to also the level of care, community interventions, primary healthcare interventions, as well as surrogate interventions. So the most important contribution of this scholarship is really to identify the large potential of outreach and community-based interventions that could be reasonably safely delivered at scale within the populations that are affected by such displacement and such insecurity. And these are also things that could minimize the risk to front-level health workers in contrast to things that can only be delivered in facilities. So the key message from this work was that this evidence and guidance exists, but it's sparse, but we at least have a framework that would allow us to undertake better decision-making that should probably be integrated within existing manuals for working in those settings. And these effective interventions can be feasibly delivered and not necessarily in a very cost-ineffective manner. So we felt that the whole cost effectiveness of these interventions ought to be evaluated in the context of impact and value in terms of longer-term outcomes. We have made a specific recommendation in the Lancet series of moving forwards with three specific developments. One is to convene an independent technical advisory group to establish a decision-making framework for intervention selection in these settings. And this could be done with a combination of existing bodies and perhaps some additional academic input. And this is where the CUGH and its partners come in. We have also underscored the promotion of data collection and analysis efforts to make the current evidence a little better and to develop a common set of indicators, if possible, for humanitarian health action. So as I close, a lot of the next steps for the branch consortium are around knowledge translation. And in addition to the dissemination of some of this recent work, which is just as fresh as a couple of weeks ago, is in sharing across different platforms like we are doing today, and to also work with development partners and importantly with the NGOs on the ground in terms of how we can implement this in the short to medium term. And that inevitably means that some of this work will need to be done in the COVID-19 reality of working with mitigation strategies that would need to be adopted by people on the ground. So we are planning three large regional workshops over the next 6 months or so in the MENA region, Middle East, North Africa, in the African region, Afro, and in the AFPAC border, and there could very well be more. And these will be focused on engaging frontline workers, local NGOs and governments, as well as donors and policymakers. We have also put out these knowledge translation briefs and advocacy toolkits, which will be coming out in collaboration with the PMNCH over the next few months. And these are specifically geared towards converting the rather technical, dense, and academic papers in the Lancet and other journals into much more user-friendly policy briefs that can be used by people on the ground. So I'll stop at this by inviting you to potentially join this consortium. This is not a consortium of elites. This is a consortium which may have started with a few like-minded universities and academics getting together, but is very much focused on expanding into low and middle income countries. And a large proportion of our consortium partners are universities within those conflict zones and groups of people who are working together to make the world a little better for women and children. Thank you very much for your attention. Over to you, Neha. Professor Neha Singh.
Thank you, Zulfi. Just going to share my screen. Okay. Thank you again, Zulfi. So today I'm going to briefly discuss our study. This is paper 3 in the Lancet series, which presents insights from what implementation of health interventions looks like for women, children, and adolescents in 10 country case studies or 10 conflict settings. So today you only see me presenting, but I would like to ask that you please note every single person's name acknowledged in paper 3 of the series, as this work was done collectively by 82 researchers from 24 institutions in 14 countries, the vast majority from the 10 case study countries. I was very humbled and grateful for the opportunity to work with and learn from everyone, the case study teams. And just to say that that what we were really aiming to do was to look at, assess the provision of sexual, reproductive, maternal, newborn, child, and adolescent health and nutrition interventions in conflicts in Afghanistan, Pakistan, Yemen, Somalia, South Sudan, Syria, Mali, Colombia, Nigeria, and DRC. So in addition to exploring the provision of these services, and it's a bit of an alphabet soup, so we abbreviated it to Women's and Children's Health, or WCH interventions, as I'm going to call them for the rest of my presentation. We also analyzed factors that actually influence the implementation of these health services in the 10 conflict-affected settings. So how did we do this work? We used both qualitative and quantitative methods and applied a framework analysis approach to describe the coverage as well as the spectrum of WCH interventions that were delivered. We also assessed explanatory variables, so these ones on the bottom, affecting variation in health service delivery, specifically by analyzing decision-making processes, obstacles to implementation of proven interventions, and adaptations of service delivery strategies to address the health needs of women, children, and adolescents in very varied geographic, political, economic, and environmental conditions. So in this slide and next, I'm going to give you a preview of our results that you can see in the paper. So we know that international and local humanitarian actors and local and national authorities are confronted by various obstacles to deliver these interventions. So for the purposes of this study, we developed health and humanitarian system building blocks, which is an adaptation of the World Health Organization's health system building blocks, and classified our findings according to the domains you see on the column on the left. I won't go into detail here, but I'm showing you figure 1 from the paper that summarizes what bottlenecks. You can see a lot of red here, so there were quite a lot of major barriers reported. Then moving on, we actually investigated what are some creative solutions that humanitarian actors have used to implement services for women, children, and adolescents in these conflict settings. So table 3, which is I've just taken a screenshot here, summarizes these in the paper, which include but are not limited to remote management, the emergence of pooled funds, localizing healthcare delivery, which Professor Paul Wise just talked about, and rebuilding trust with communities. So I'm just going to show you the next 4 slides. What are the key findings from this paper? So we found that despite large variations in context and decision-making processes, there was a certain set of services that were prioritized. So antenatal care, basic emergency obstetric and newborn care, or BEMONC, immunization, treatment of common childhood illnesses, infant and young child feeding, and malnutrition treatment and screening were prioritized in the 10 conflict settings. However, many life-saving services, including the majority of sexual, reproductive, newborn, and adolescent health services, were reported as not being delivered in the 10 conflict settings, and interventions to address stillbirths are completely absent. Priority predefined packages of WCH services are not commonly agreed on and implemented in 10 conflict settings. So an effective strategy to deliver care to women, children, and adolescents should include proactively defining and agreeing upon an evidence-based comprehensive package of interventions, taking into account existing evidence and guidelines, such as the Interagency Field Manual on Reproductive Health and Crises, the Newborn Health and Humanitarian Setting Field Guide, etc. And Zulfi already referred to paper 4 in this series, which was led by Michelle Gaffey. So I would ask you to to read that paper for more information on this, including the framework for how to prioritize interventions. We also found that the priorities of donors are actually the primary drivers of influencing the what, where, and how of implementing these interventions. And interpretation of women's and children's health outcomes in conflict settings are particularly context dependent, given the myriad of complex factors that constitute conflict and their interactions. So we need to exercise caution when generalizing the mode of delivery of health interventions and their effects because of the limited comprehensiveness and quality of data that are available from these settings. And while continued efforts to improve systems and quality in such settings for data must continue, for the moment, the community must recognize such limitations when making decisions. And similar to what Professor Wise was saying, working within the political and governance systems in conflict settings is increasingly challenging, given the dynamic nature of modern conflict and the expanding role of non-state armed groups who are often in control of large geographic areas. We found that decision-making processes in the different settings also varied by government, organization, and context, and could be categorized into 4 models that are quite dynamic, so not mutually exclusive. So in some places, decisions are made in quite a centralized manner, for example, through ministries of health, through governments, through national authorities. Others, it's more humanitarian actors-led. In some places, it's collaborative, where people are working together, both sets of actors. And in some places, it's more of a gatekeeping model. It's also really important to stress that the health system capacity of a setting before conflict is and thus the readiness to respond in a systematic manner vary greatly by case study setting. So it really, important enabling factors include the income status of countries. So for example, are they middle income versus low income? So for example, Professor Halakatas, who's going to speak after me, led the Syria case study. And if you look at the Syria paper, you'll see that the health system in Syria was actually quite good before the conflict started. Whereas, for example, in northern Nigeria, you find that the health system was really weak even before the conflict started. So pre-conflict health system capacity is a determinant to how, and really influences how services are implemented. That being said, the humanitarian system is creative and pluralistic, and it has developed some novel solutions to bring life-saving services closer to populations, as I showed you earlier in that table. So some of these include hiring other types of health workers, often from affected communities. So for example, community midwives, community health workers, traditional healers, traditional birth attendants, and also using new modes of delivery. So for example, remote management, we saw that in Syria, and then technology such as WhatsApp, mobile clinics, treatment posts, home visits, and so forth. These last 2 points, I would say, are quite critical. So it's critical that we recognize and value the role of local actors to improve timely and appropriate delivery of these services. And I know Professor Wise just alluded to that in his talk as well. So the humanitarian system must go beyond lip service and allocate enough financial, human, and other relevant resources to local actors, while also ensuring that the risks involved in delivering care at the front lines and conflict settings are not actually transferred to local actors. And finally, last but certainly not least, while the needs of conflict-affected communities are great, their voices are also often unheard or overlooked. It's therefore crucial that they have a seat at the table and that humanitarian actors listen to them when decisions concerning them are made. So I'd just like to end by saying that while it's clearly imperative that the world make more efforts to reduce the risk of conflict, until that happens, improving the delivery of health and nutrition services for women, children, and adolescents affected by conflict remains an ethical and moral responsibility. Thank you. And over to Dr. Halak.
Thank you, Neha. Okay, so I will be presenting on data from the case study we conducted on Syria on behalf of colleagues from the London School of Hygiene and Tropical Medicine and the American University of Beirut. And for us, being based in the region has enabled us to conduct research and interventions that aim to improve the health of populations affected by conflict, including the Palestinian, Iraqi, and Syrian conflicts, as well as our own context in Lebanon that had faced various conflicts and violent events over the last few decades. So I will start by giving some background regarding the conflicts and resulting population displacement in the Middle East, then briefly discuss some of the specificities of this region and how they impact the health of women and children in conflict. And then in doing so, I'll zoom in on our findings from the Syria case study and highlight some intervention and data gaps, as well as lessons learned. The crises in the region have been largely urban conflicts and have led to mass displacement, both internally and across borders. So the map on the left shows the internal displacement flows within Syria, with about 1.7 million people becoming displaced just in 2020, and over 6.7 million total internally displaced people today. And on the right are the numbers of refugees that have crossed borders into neighboring countries, today standing at over 5.5 million. And these dynamic and protracted crises have led to variable living conditions and access to healthcare of the populations that emerge from these crises. So for example, in cities destroyed by conflict, shown here, in IDP camps inside Syria, in camps and informal tented settlements in neighboring countries, and also in urban host populations in Jordan and Lebanon. And these contexts influence intervention coverage, access to healthcare and health indicators of women and children, as we've previously shown in work focusing on the differentials across these different contexts of displacement. So some of the specificities of Middle Eastern countries affected by conflict are, as Neha mentioned before, that these were previously middle income with largely functioning public health systems, and pre-war care seeking was medicalized, And the disease profile was very much one where the epidemiological transition was well underway. Syria, for example, had made improvements in both maternal and child health indicators, including mortality rates and skilled attendance at delivery, which had reached about 96% by 2008. Having said that, and in Syria, inequalities across regions were strongly evident pre-conflict. And this here is a graph in a paper by my colleague Sausan Abderrahim, showing stark differences in babies weighed at birth, as well as delivered at home across Syrian governorates before the war. The implications of pre-conflict status include the fact that health-seeking behaviors during the conflict are often aligned with the pre-war standard, but also the Syrian conflict is characterized by the targeting of healthcare facilities and the exodus of skilled health workforce, which contributed to severe deterioration in the health system throughout the conflict. And as an example of the combination of the effects of the pre-war context and the volatile security context, in our case study, we found that Syrian women reported to prefer home births or request C-sections, for example, to mitigate the risks associated with the insecure environment, leading to increasing rates of facility-level C-sections, as shown in this graph, and as compared to the already high pre-conflict C-section rates shown in the black horizontal line. And these increases were witnessed across geographic regions and throughout the conflict. These are data from 2014 to 2018. The conflict in Syria also led to fragmentation of governance on the Syrian territory amongst the multiple authorities and factions. And the response to this was the establishment of a complex multi-hub structure entitled the Whole of Syria approach, whereby various hubs managed the humanitarian response, including cross-border and remote management of interventions. And these modalities relied on local actors and community health workers to deliver interventions through outreach activities to women and children. And they were able to reach women and children with interventions. But this complex structure took time to establish and to begin coordination of responses and delivery of these to populations in need. And this also led to variability in coverage of interventions geographically and over time. And as an example of the impact of these modalities on the variability of coverage, these are data that show first the initial drop in coverage of childhood vaccination during the conflict, with national data shown here in red and blue. So red is DTP coverage and blue is measles vaccination. Then the stabilization of vaccination rates at a lower rate than it was previously. However, data from specific geographic areas actually show the differential reach of vaccination. So for example, in West Daraa and Konaitra in southern Syria, routine immunization was disrupted and vaccinators could not easily reach populations. And this resulted in low DTP coverage, for example. But humanitarian agencies were actually able to conduct 2 cross-border measles and polio immunization campaigns, allowing the coverage of measles vaccination to be much higher during the same period of time. These issues around access to populations, their displacement and dispersion also led to major data gaps emerging from Syria during the conflict. And with the additional challenges in sampling and loss of data collection capacity due to forced migration and brain drain, as well as a breakdown or undermining of systems for vital registration and national health information, what we find is that for a whole region, that there are whole regions for which data are very difficult to obtain. And this here shows the example of the number of indicators for women and children's health that we were able to extract from a review that covered about 3,300 documents. And it highlights data availability in areas where international humanitarian actors were operating across borders, from Gaziantep in the north, from Amman in the south, and the lack of availability and accessibility of data across the rest of the country, although clearly there are populations that live in these areas. So our findings really document the creative way in which humanitarian health interventions were managed in a dynamic and often volatile political insecurity environment, and show that these adaptations were able to prioritize and reach women and children with interventions, albeit with an initial lag. Some of the other major gaps we found were in a lack of delivery of adolescent health services, as well as delays in initiating family planning services. The variable access to populations and these data gaps lead to differential coverage, but also more importantly, limit accountability and monitoring, and hinder the evaluation of the delivery of interventions that ultimately aim to improve the health of women and children in Syria. Thank you so much. I will now pass you on to Professor Barry to lead the Q&A.
Hello. Hi, thank you. I think all the panelists should join us. I'm going to start. We have a lot of questions, but I'm going to start quickly. The first one is from Len Rubenstein, who thanks you for the presentations and then asks, to what extent does the research help understand the degree to which the decline in women's and children's health are a product of the conflict generally, and the degree the change was a product of the violence against healthcare and the differences in different conflicts? So the question being, is it on the actual workers, the hospitals, or on women and children? Was that teased out? That's my interpretation. Who wants to take that?
I can have a go. So in the current exercise, because this is based on demographic and health survey analysis, it's not been possible to disentangle the impact of conflict on targeting of health workers and facilities, which is not a small contribution. But in the current exercise of looking at available data sets at population level, we have not been able to parse out the relative contribution of these attacks against facilities or health workers. But we have indirect data to indicate that that's not insubstantial, and not in terms of a direct effect only, but indirect effects on provision of health services. We know from, and this is available in some of our country case studies, as to the absolutely detrimental impact that we have had by targeting of hospitals, and particularly hospitals that have been very clearly identified as referral centers for more complicated and sophisticated care. So your question is absolutely valid. We should have some estimation of what proportion of the burden of ill health and disease or mortality in these geographies is attributed to that one factor. We don't right now. We have some estimates on the number of health workers killed or the number of facilities targeted, but they would have to be indirectly triangulated against this population-based data. Maybe, Paul, you might have some additional observations.
Thank you, and thanks to Len for such an important question. We should be able to track and have been tracking different types of interventions that are heavily dependent on health system infrastructure, and others that do not require substantial health infrastructure, and looking at differential provision, but also differential outcomes in these different arenas of effect. And that is allowing us to begin to disaggregate the relative contribution of healthcare services per se, healthcare infrastructure, and those generally associated with the destruction of the essentials of life.
Thank you. The next question is, well, Paul Whitney, who has a couple of questions that I'll combine. U.S. embassies have released some funding opportunities related to preventing youth radicalization, but those putting out these funding mechanisms tend to shy away from health issues. How do we move policymakers towards an understanding of the connections among health and policy goals? And then he goes ahead and asks, he's a U.S. university that has partners on the ground in Syria and Kurdistan. How do they proceed to join the consortium? And there are a couple of questions that ask, how can folks get involved?
Zulfi, do you want to take that part of the question
Well,
first?
it's very simple. I mean, you get involved by just reaching out. So we have a website, branchconsortium.org, and just send us a note, and we would find a mechanism and a way of linking you to the consortium at large. So it's not too complicated, and particularly academic centers are most welcome, especially if they are based within the geographies. So please just drop us a note.
And I don't know, Hala, if you want to take that, but the first part of the question, but I do want to mention that one thing we did find was how siloed, how confined the different arenas of activity in these areas can be. Also, to point out that the governance, the restrictions on how NGOs can interact with not only armed non-state groups, but also communities that fall into territories controlled by opposition leaders and militias, has made it almost impossible to engage with communities that are deemed oppositional to the state. And in fact, there are financial or even criminal sanctions that can be brought against humanitarian groups who attempt to engage with oppositional groups, or precisely the groups that likely are going to be intensely radicalized in the manner the questioner is speaking.
Thank you. I'm going to combine two questions from Afaf Malay and Cecilia Sorensen. Did any of the studies look at the relationship between the shortage of hospital professionals in conflict areas and the outcomes of morbidity and mortality for women and infants? And then Cecilia asks, which I think is a related question, to what degree is the lack of women's healthcare related to the lack of healthcare providers or the interruption of their education as a result of the conflict?
So, great question, and I think the analysis that Iran Ben David led in terms of the relationship, both geospatial in terms of distance and severity, is reflective of the relative paucity of services in those areas. And the closer you get to the epicenter of conflict, where there is greater insecurity, and you also have relative absence of particularly trained healthcare providers and also facilities that are stable enough to provide those services. So that relationship is very clear. And it is not only just the direct effect of conflict, but it's also the indirect effects that relate to other provisional services. Do we have global estimates on what is the population need versus health workers available in that space? That is data that is very much needed, particularly for protracted conflicts. And those data are not readily available because a large proportion of care providers or people who provide stable care in this particular space are not public sector staff. I mean, they are generally representatives of NGOs, both local NGOs, international NGOs, and relief agencies. And they typically do not stay in one place for too long. And they're also susceptible or let's say sensitive to security dimensions in those areas. So we try to look for that quite actively within our global review and country case studies. But I'm not aware of any single regional estimation which gives you those figures in contrast to MNCH and drivers in other populations.
So that kind of segues into a question from Catherine Campos, which I think you sort of answered the first part, is there any real-time data collection implemented that can be successfully implemented in the delivery of health service interventions? And are there any programs that are successful in that efforts? But her second part is also pertinent, where she asks, how can we cultivate strengthening collaboration between local humanitarian actors and NGOs to improve on the ground conditions? Because they're often, as all the panelists know, working in silos.
Hala, so you should try and answer that. Hala and yeah.
So the first question is, Is there any real-time collection? And the second is collaboration.
So Michelle, I can answer the first part. The real-time data collection is very limited. It's based on short surveys, smart surveys, or limited data collection for service delivery. There have been a lot of effort to collate it all together to make it more population-based and all. I would say it's a glass half full. It's much better than it was a few years ago. But we are very hopeful that some of the emerging capacities with remote sensing, with geospatial methods that allow you to look at population clustering or clustering of facilities in relation to needs without necessarily putting people at risk, are going to be the way forward. It's a different issue now that geospatial data collection in some of these conflict zones has also become very complicated, because I mean, it actually puts the people who collect that information at much greater risk because of drone warfare, targeting. So, you know, although we have gained in technology at one end, but unfortunately that technology has also been used for conflict-related activities. So for warfare, much more than for civilian use. But over to my colleagues.
So I was just going to comment on the fact that there are scattered efforts for real-time data collection, as Professor Bhutta mentioned, but also one of the big issues is how do you get at things like sampling frames and denominators in these populations where there are constant shifts in denominators and in people moving from certain regions to others. There have been quite a lot of small scattered efforts based really very much on community informants, but as Professor Bhutta also mentioned, this puts these data collectors at risk sometimes in terms of security risks specifically. And then data are often politicized and quite sensitive in these kinds of contexts. So we find that it's very difficult to get accurate data from different places at different points in time, because these are viewed to potentially serve the interests of certain political actors against others. And so these become very sensitive and are very difficult to be able to access often. Thank you.
And the collaboration question? Anyone want to take that on? That's a tough one.
Would you mind repeating it, Michelle? Sorry.
Just how NGOs and people on the ground can collaborate better. They're often working in silos. Is there any mechanism?
I mean, I could take a stab at it, and then I would welcome my panelists to comment. I think there's a difference between local NGOs and international humanitarian NGOs. So I think there's been a lot written about this. Well, especially in the last few years, if you just look up work on localizing the humanitarian response, localizing aid, I would say that there's a lot of talk about, you know, transitioning to putting, you know, local actors at the front line. But what I would argue is that for that to work, the system has to enable it, and it's not just about, you know, there need to be ways to actually financially support local actors to actually respond. There has to be training, there has to be sort of physical resources or commodities given to them. And I know, for example, during COVID-19, there were a lot of funds released, but through OCHA, if I recall correctly. But in some ways, the systems are not quite updated, and it's been criticized because in the end, the money was mainly distributed to UN agencies rather than to the frontline actors, and it wasn't possible for them to get money, for example. So I think in order to really sort of transition and to give sort of power and enable actors more locally to respond better, we need to actually change the systems and actually cede power as well from more northern-led, more international humanitarian NGOs to actors closer to what's going on.
Can I just comment on that as well, just in terms of the collaboration from our perspective, being academics in a context that is affected by conflicts and where populations affected by conflict reside. We found that working closely with local NGOs and actors as academia and building these relationships over time have really allowed us to establish quite strong collaborations and really try to build as academics the evidence that is needed by local actors on the ground. We do find that there are disconnects in terms of timelines and priorities of academia versus NGOs, and the dire kind of humanitarian needs that need an immediate response versus academic timelines for some of this work. But being embedded in the context, I think, has helped us from our perspective to be able to do that.
Thank you. And before we end, just a quick question by Rachel Kaplan. Have you included transgender women and girls in your analysis? And then there was another question about girl children.
So I could maybe quickly comment on that from the 10-country case studies we did, and Hala, please jump in. We did include adolescent girls, and that's part of, we were looking at adolescent health services, actually both for girls and boys, but just to say that we found that adolescent health services largely were absent, and Professor Bhuta mentioned that as well. Not within this work, but I've in some other work I've done on looking at health of conflict-affected populations. We've been looking for what's going on with people of from sexual and gender minorities, and the evidence base on that is really weak, and partially because it's not been prioritized in programming necessarily, or it doesn't receive the amount of funding. So I'm thinking, and in some places it's illegal to provide services. For example, in some places I worked in, for example, in northern Uganda, you can't. It's illegal. So so I think it's a complicated question, but at least in the Lancet series, yes, we did look at adolescents.
Well, I'm going to end here. I think that complicated questions and complicated answers, and your series really tackle some of the most important complicated aspects of giving care during conflict zones. And I just wanted to say, for people who came in late or didn't have a chance to see this full taping, it will be taped. It will be sent out to anyone on our email listserv, and it will be on the CUGH webinar. Keith, do you want to say a few ending remarks? Well, while Keith is getting unmuted, I'm going to thank all of the panelists for your incredible and very thoughtful presentation. Are you unmuted, Keith?
I am, Michelle. Thank you. I'd like to really thank everybody. You all did such an outstanding job, as Michelle said. A couple of points just that came through, if I can suggest. For Professor Rubenstein at Johns Hopkins, I really encourage all of you to look at the outstanding work that Professor Rubenstein does. He has an initiative to protect healthcare workers in conflict zones. Please join that. Look at what they've done. It is absolutely outstanding. Dr. Sorensen, Cecilia Sorensen, who asked a question, she's come up with a very intriguing proposal, and it deals with the gap in healthcare services, particularly amongst refugees and internally displaced persons camps. There's a swath of people in those camps who are health workers, or, as she alluded to, health workers whose training has been arrested. That's an opportunity to train those people, get those people's skills up, because they can be trusted healthcare providers in refugee camps where there's an extraordinary gap. And finally, I think all of us heard clearly that it's really easy to start a conflict. It's difficult to stop a conflict. Look at the Democratic Republic of the Congo, where more than 5 million people have been killed in more than 20 years. And when I think of our great challenges, we have a responsibility to protect, but we don't have an obligation to act. We have a legal framework without an enforcement mechanism. And embedded in that are some of the great challenges of our time that will help to address the the incredible challenges within the series. And again, thank you to all of our speakers. As Dr. Berry mentioned, this will be on our CUGH's website by next week. And I'd like to thank Jenna Smith for the great job she does in producing these webinars. So thanks everybody for joining us today, and we look forward to seeing you soon, if not at our upcoming Global Health Conference in March, CUGH2021.org. Register and be there. Thanks everybody.
Bye.